All right. Good evening, everyone. Dr. Twyman here with Dr. Maupin tonight. We're going to be chatting about hormone replacement therapy, but I want to give you guys a quick tour of the new red light at Apollo Cardiology. So I'm probably going to be blinded when I look at this thing, so let me just flip the screen around. So this is the 8-foot tall EMR Tech Firehawk. It's a beast of a panel. It's over 300 pounds and it's 500 watts. I'm going to change to the side so I'm not get blinded by this thing, but this is the sunset in St. Louis, and we're probably guiding in flights to Lambert Airfield tonight. So in future, we'll be doing some more talks about photobiomodulation, but just want to show you guys what this looks like. So, all right, head back out to the lobby, and this is Dr. Maupin, and let me hook up the camera here. All right. Flip the camera around for you.
Very
Let's see if I can actually get everybody in the screen.
I'll move over this way.
All right.
Okay.
That works.
Okay. Not bad.
Not too bad.
We just have to get really close.
Maybe
Oh,
sometimes it goes sideways, but it'll be a little bit funky
That'll be
with us,
fine.
but we'll fit. All right.
Perfect.
I know we're sideways, but we'll flip back around when we answer questions. So, all right. So
Hi.
this is Dr. Kathy Maupin. She's the founder of BioBalance here in St. Louis. She's an expert in hormone replacement therapy. And we're just going to chat about who's a good candidate for hormone replacement therapy, and a little bit about pellet therapy, which is something that they specialize in over at BioBalance. So, introduce.
Okay.
you.
All right, that's it. So, 20 years ago when I had, I was a gynecologist. I am a gynecologist, and I was an obstetrician as well. And when I had my own critical disaster, when my ovaries were taken out, I had a hormone disaster. And that brought it home that when your hormones are gone, your brain's gone, your body's gone, your personality's gone, your sex life's gone, and your husband may be gone soon. And so it was a huge problem for me, but it was also a reality test that told me how bad my patients must have been feeling, but weren't comfortable enough to tell me that they felt that bad when they didn't have their hormones. So I then had to investigate who could give me the right hormones. I was really good at hormones. I did hormones in all kinds of bioidentical fashion since 1986. So this was 2002, and I knew how to do creams and gels and vaginal tabs and all different, every kind of hormone. We even did rectal suppositories of progesterone. I mean, we did the first PMS clinic. We had so many PMS patients in my practice. So it was really close to my heart. And then when I had this and it didn't get better, I had to go searching, and I found a doctor in California. And his name was Gino Totera, and he's no longer with us on this planet. And so he taught me what he knew, and it was wonderful. He treated me first, and I mean, I felt better overnight, and that was testosterone pellets. So even though I had always done hormones, even though I had always done different things, it had never made people feel completely better. Mm-hmm. And then when I had my ovaries out, and I needed to have a complete revamp of myself when they were gone, this was the only thing that really made me completely better. And it did make me better, and pretty fast. It was just a few weeks before I was sleeping and felt great. And it took me 9 months to get my weight down again. I mean, it went on like in 3 days, and it came off in 9 months. So it took all of dieting and exercise too, but I got my body back. So that was 20 years ago. So now I have left OBGYN behind, even though I know all the things about GYN. I no longer know all the new things about OB. But now we take care of people who are over 40 usually, or women who have had a hysterectomy early, and we also take care of men, because all my patients said, please just take care of my husband. And so they would just beg me. And so finally I was trained to take care of men, but I hadn't taken care of men since medical school, except for infertility patients. So I had to go back to the books a little bit and get retrained. But I take care of both men and women, and we do long-acting pellets, which is great because I don't have to worry about whether my patients take their pills or not, or if they put their patch on, or when they tell me their hormones aren't at the right level, I know what hormone I gave them. They're under the skin, they're in there for 4 months for women and 6 months for men. So I know if I've gotten the dose right or I haven't, and I know what to do with that dose when I look at their labs and talk to them. So we do, the fact is that my patients get healthier. They don't just feel better and get rid of their hot flashes, they actually get healthier.
And so that's the women. So on men, who are good candidates for hormone therapy from a man, for mostly the pellet, because there's guys doing Sivanade, IM injections, they're doing creams and such, but who are the good candidates for pellets?
There are some people who can take the shots and it doesn't affect their cholesterol, make their cholesterol worse, it doesn't make their lipids worse, it doesn't increase inflammation, but those people, usually the older people, usually men over 50, can't tolerate the shot as well, and they get a lot of side effects. They get a lot of, they end up with body hair all over, kind of the old ape look, with that body hair everywhere and no hair on the top of their heads. And so that's something that we don't tend to see. And we manage everything with our guys. If they're losing hair, then we take care of that. We change doses. If they're getting, usually it gets rid of your belly. There's a 10% of the population it doesn't. So then we have to use another medicine. But we know how to troubleshoot and get our patients back to health. So I'd say it would be men over 50 and men with medical problems, men with high cholesterol, lipids problems, heart attacks, but also men who just have a family history of those things, because they generally can't tolerate the other types of testosterone. Or men who just can't remember to put the patch on, take the gel, or do that, because there's a lot of guys that just can't remember. And so then they're up and down, and that's worse than having low testosterone all the time.
And then how do you come up with a dose of the testosterone that stays steady for that time and they just don't have the peaks and valleys?
Well, that's an art and a science. And I was trained to start out with a certain dose for an average man, which would be a man whose surface area basically is based on 170 pounds, 5'10", I think is the average, what they consider the average male. And then if I have somebody who's 6'7", I have to increase for that. If I have somebody who runs marathons or exercises excessively every day or a lot every day, maybe not be excessive, then I have to increase dose for that. If I have somebody who, basically I'm increasing the dose from a base that I know I'm going to get enough testosterone, then I have to increase it so it lasts 6 months. So pellets, basically, if you have a 200 milligram pellet, it'll last 6 months. If you have a 300, it will last 8 months, but we don't generally use the 300s because it's not as predictable as the 200s. So we use a combination of 100s, 200s, and 300s to increase the dose immediately when you start, and then to keep it even, we switch back to 200s and 300s at the end. So it's not easy to train somebody to do that. It really is kind of an art for a doctor or a nurse practitioner to learn to do that. But I have a formula that I have in my brain, and my nurses know it, my nurse practitioners know it, my other doctor, Dr. Sullivan, is great at it. And so we kind of have a way to figure out what we have to go up or down for women. And women are trickier because they've got two hormones. They've got estrogen, they've got testosterone, and when you bring estrogen up too high, it makes the free testosterone, the active testosterone, go down. So that's very tricky, and it's a lot harder to manage. So when we're dealing with a woman, that's why there's so many places that take care of men's testosterone but don't take care of women's. And we have the problem of having a uterus, and when we give estrogen, we might make people bleed. So we have that figured out so that we don't have that happen very often, but sometimes it still does, and being a gynecologist helps.
Sure. And can you predict the people that are going to have more issues with the conversion of testosterone into the dihydrotestosterone, the DHT? Because that's one that usually causes more of the hair issues, is that right? Right.
Well, hair loss in women usually is a lack of estrogen, and that's frontal hair. If they have hair loss all over, it's usually thyroid. Lack of too much DHT, I don't see very often in my patients. That's much more common with the depo-testosterone.
Okay.
It is less common with the pellets, but we do see it every once in a while, and we have to take care of it. We usually use saw palmetto, or we call it prostate formula, and the women use the prostate formula to help the excessive DHT, which is a byproduct of testosterone, not to affect their hair. So we check out everything to make sure that their hair is going to stay thick or get thicker. We treat their thyroid as well.
Okay, awesome. I know we had some questions. We'll go through those in just a moment, but is there anything that you want people to know about hormone therapy? I know that there's definitely a lot of myths out there in hormone replacement therapy that it's bad for your heart and all this stuff. So I know, we've talked about, on your show before, the Women's Health Initiative was not really put together well.
It wasn't helpful, and it wasn't very. It didn't really tell us what was wrong with hormones. What they should have said is Provera, which is the progestin that people take with estrogen, was the problem. But they never said that. They just said hormones are the problem. And so that made everybody afraid to go off their hormones. I can't tell you how many hundreds of phone calls we got the week after that came out. People were they're like, give me my hormones back. I want my hormones back. And we never took them away. Mm-hmm. They just didn't take them for a while. Mm-hmm. And they're like, I can't live like this. So that was before I even did pellets. That was oral hormones. And I don't do oral hormones anymore because we did find that oral estrogen, with or without progestin, causes blood clots. Now, if you take estrogen without it being oral, if it doesn't go through your liver, it does not increase the clotting factors. So it does not cause blood clots. So, you still can get a blood clot if you're on estrogen, but that's not the cause. So that's why we feel much more comfortable. Pellets are the safest way to get testosterone and estrogen. So I feel good that I'm not causing trouble. I'm not causing problems. I'm making people healthier. And as they age, they'll age slower. Basically, we will see that in women especially, we see better lipid panels. We see less inflammation. We see weight loss. We see fat loss and muscle gain. So we have to ask them to exercise and diet like normal people have to be healthy. But besides that, that's never going to do it all by itself. You need, if you're over 40 or 45 at the very oldest, you have to be on testosterone. And if you get to menopause after that, then we add estrogen.
Okay. All right. I know for the people who are just joining, I know it is sideways. I know it's not the optimal format. This video was being saved. I'll put it up on our YouTube channel, and we'll share a link with Dr. Maupin's audience so you can see it, the right way eventually. So I know we have some questions here, so I'll flip the screen around and we'll answer the live questions and go through some of the other ones. So, all right. So let's see. So question, does HRT cause breast cancer, and is it recommended for women over the age of 70?
That was what they got wrong at the WHI study. So it does not cause breast cancer. When you get breast cancer, your cells actually change. And when they change, they can become sensitive to estrogen and progesterone. So then they could be stimulated. But the breast itself is not going to be, the cells aren't going to change into cancer because of this. It's much more common that obesity, alcohol, inflammation, terrible habits, not sleeping, not exercising, those are the highest risk things for breast cancer. So if you don't want to have breast cancer, stop eating sugar, don't eat carbs, because cancer loves sugar, and exercise every day, and that will decrease your risk.
Excellent. All right, and this one goes along with what I do on a day-to-day basis. So what are the long-term effects of HRT on cardiac health? So,
well, there's HRT and then there's testosterone and estradiol.
Right.
So HRT usually means estrogen and progestin. And when we look at that, if you've had a hysterectomy and you're just taking estrogen of some kind like Premarin or estradiol, then or estrase, then they show that you have less cardiac risk and your lipids come down. If you add progestin like Provera, then your risk goes up again. Okay. If you're taking pellets, we don't give progestins. We give progesterone, pure progesterone, in a bioidentical way, and we use pure estradiol and pure testosterone, and that decreases your risk for heart disease.
All right. I think we already answered that one. I guess this one. What about if you have estrogen dominance? Well, there's medication supplements that can...
Right, we use supplements, or we use a Arimidex in the pellet, and that decreases estrone and estradiol.
And a question, what about a woman that breastfed her children in the past? Will HRT cause her breast to relactate due to hormone increase?
It should not. If you start lactating, you need to have a complete workup for a pituitary mass, or there may be something going on in your breast itself. So that requires a workup.
All right. Answer some of the questions I got sent off beforehand. Let's see if I can get those actually to pop up on the screen. There we go. more questions than I thought they were to ask about that. Yeah, we'll
There
take
was
them from
one
the
about
top.
sex drive, and we didn't talk about that.
Yeah. The question is, do you feel it adds to the quality of life or the quantity of both?
It's both. Testosterone, there's lots of articles, no one talks about it. For men, there's tons of research that say that taking testosterone lengthens your life and decreases your time when you're going to be dependent on somebody else, when you're not going to be able to walk, when you're not going to be able to see, when you're not going to be able to get yourself out of a chair. It helps your muscle mass. So it helps your quality of life. It also helps your sex life, which makes your quality of life better. Whether or not you have a partner, it still makes your quality of life better. So these are all, it also, I mean, it makes you healthier. In general, you'll lose weight. In general, you'll gain muscle. In general, you'll be more active and you're motivated to eat properly because you start feeling better. Your mood is better. We often get people off of antidepressants that they've been on since they were in their 40s or 50s.
Excellent. Is there anything else? Question. Is synthetic testosterone necessarily bad for you? If so, what can I use instead? Well, we think we went through this a little bit.
Well, if it's talking about women, they've taken estrotest off the market for a good reason because all oral estrogens cause liver damage and that it's not worth it. That's not a good way to take testosterone, but that's the only thing that the FDA allowed women to have, which is why I wrote the book, The Secret Female Hormone, because women need testosterone, especially after 40 and definitely after menopause. So if you don't have testosterone, your bones thin, your muscles go away, your belly gets fat, you get fat, and you stop having the energy and your personality changes. You really need to have testosterone to be normal. So those are all things that keep us young and healthy. And basically, you need to have testosterone in a natural form, but FDA did not pass the patch that had testosterone in it. And it was a natural form of testosterone, and they said, no, we don't think so. People might get some facial hair, which we take care of by using spironolactone and just prevent facial hair. So facial hair isn't life or death. And we can take care of that.
A lot of testosterone questions. Let's start at the back at the beginning for the people that asked this one. So, I already asked questions. This was one. Have you found success in increasing hormone levels with glandular supplementation? So I don't know if they're asking about thyroid or for, female or male hormones, but.
Well, I don't know of any glandular testosterone unless you want to go to the meat counter and get some type of testicles from some animal. But there is something called androgen, which is an adrenal natural hormone from the adrenal gland of a cow. And we do use that to suppress overactive cortisol, and it works. So we use that in the morning, and that decreases cortisol. There's no drug for that. Nobody has a drug that will lower cortisol levels. So that's one way we use it. And we also use, I think it's pig thyroid. And the pig thyroid is something that we use in Armour thyroid. So it's Armour, kind of like, it's like the Armour hot dogs.
Right.
Yeah, but it's pig thyroid, and pig thyroid can be taken orally, and it works better for women, not necessarily for men, but for women it works better to replace your thyroid. It has both T4 and T3 in it. Women need the T3. Men make more T3 than women do. Don't know why. I still don't know why. But we need to have the T3 as well as the T4 to be normal and to have normal weight and normal lipids, because low thyroid causes high lipids.
Right, and now the way that happens is the LDL receptor, it's like a little catcher's mitt, sits on the outside of the liver and clears the blood of the lipoproteins. If you don't have the proper thyroid hormone, you don't put the little catcher mitts out there, and so the particles just go around the circuit more, and more risk that they get stuck to the arteries. Good question there. This might be a record for the number of questions we've got asked. think we're to sort of ask this person, but I'm not going to pull up on the screen. It says, like, I'm feeling like I'm dying without HRT. What type of doctor would you see to restore hormones in a 66-year-old?
I'm 66.
Yeah. Right.
I'm going to take this until I die. So, I need hormones. Some people don't need them as much. They can live, but they don't live very well. But some people like me, I can't really do my job and think clearly. I'm depressed. I can't be the right weight. I don't have energy. I don't have a sex life. So if I don't take testosterone, it's really important. And estrogen is really important for a lot of other things, but it balances the testosterone. It also gives you vaginal wetness. It also keeps you from having painful intercourse, which testosterone helps somewhat. In my breast cancer patients, their doctors let us give them testosterone, but not estrogen if they have estrogen receptors. So in many ways, the testosterone takes over for the estrogen, and they still are comfortable having sex generally. Sometimes we can use for them a little estrogen cream, but for you need estrogen and testosterone, and if you have a uterus, then you need progesterone in a natural form, and that's what I do. So usually gynecologists who specialize in this are the people that you go to. My daughter's family medicine, and she works with me, and we do the same thing. But she understands a little bit more about men than I do, so she helps train me.
Yeah.
but both family medicine and gynecology have a lot of experience in this, but our training programs don't usually teach us this. You have to get extra training to do this type of medicine.
Yep. I learned a lot of stuff in medical school and residency and fellowship, but I've taught myself more in the past 8 years than I learned in all those other times. So, all right.
We're not taught about red lights.
No.
And I love the red lights.
Yeah, we'll do a photo modulation talk pretty soon, but there are interesting more biohackers using the red light therapy to boost their testosterone levels. So red light stimulates the mitochondria. If you stimulate the mitochondria of the gonads, there's probably going to be more testosterone put out. So
it works for men and it works for women before menopause, but it's not going to work after menopause because our ovaries just die.
Oh,
but you guys can get more testosterone that way.
So I just waved at your daughter. She showed up.
Hi, Rach.
Question is, how do you manage the seasonal fluctuations in hormone levels? I think part of this got cut off. It says like UV lowering. I assume it means that like UVA lowers hormones, when UVA starts going away later in the wintertime. But as you were saying earlier, it's mostly thyroid's fluctuating, but not so much sex hormones.
Usually as we get to winter and it's darker and it gets colder, we have to boost the thyroid dose if we're giving thyroid. If we're not, then you could take some iodoral or iodine drops to help your thyroid actually work better. But if your thyroid isn't working, then you can actually increase your dose for the winter and decrease it in the spring when the time changes. Testosterone in men usually goes up in the spring and up in the fall and down in the winter. So that's just kind of something we maintain from caveman days.
Yeah.
And that's when people made babies so that they wouldn't be having babies in the winter. So that is one of the things that we don't usually adjust, because we usually have people at a really good level and it's even. We don't want to make them go way up and then way down, and we don't want to over treat them, especially with men. Men want more. Give me more testosterone. Give me more. But see, as testosterone goes up, you hit this peak where it's perfect for you. If we go over that, then you start not feeling it. All of your receptor sites are saturated and they're numb and they don't respond. So they just kind of go, yeah, we're not going to give you that kind of the good feeling in the morning, or we're not going to make you feel sexy, or or not fix your ED. There's a perfect level, and we try to reach that, but we don't try to go over.
Okay. Excellent. That. Testosterone.
It's pretty cool.
Yeah. Dories. I think we got the majority of your other questions. I think there's one other person that put up here is, can you start bioidentical hormones 10 years post-menopause?
Yep, you can. Anytime I see patients of all ages. I see that people before they hit menopause, but they have low testosterone. And I see women who are in their 70s, sometimes 80s, depends on how healthy they are. I mean, if you don't have any reason, such as breast cancer, with estrogen receptors, that I can't give you estrogen and testosterone. I could still give you testosterone, but at any age we can start. I'm not sure when they started that, except that they were backpedaling from saying, oh yeah, the estrogen's terrible, because they read the WHI study wrong. Honestly, they just read the headline. And so they were backpedaling. They go, oh yeah, you can have it for 3 years. No, you can have it for 5 years. Then they changed it to 7 years. Then they changed it to 10 years. So there's really no study that says you have to stop it at 10 years. And I'm never stopping it, especially this form. Any type of bioidentical non-oral estrogen is just going to help you stay healthier as you go. It is not going to cause you to have any problems.
Okay. And what kind of workup would you do for somebody who's already postmenopausal, saying they're new to hormone therapy?
Well, I always do an ultrasound if they have a uterus, because I want to make sure that there's nothing inside their uterus that I am going to then stimulate, because the uterus is still there. It's so responsive to estrogen. We give estrogen to somebody who already has a full uterus filled with maybe pre-cancerous tissue. You know, it's going to make them bleed, and it's going to make the cells maybe change in the uterus, not the breast, but the uterus. Mm-hmm. So we try to make sure everybody has the workup, they've seen their gynecologist, they've done their ultrasound, doesn't matter which age. If they have a uterus, we want to know what's inside. We make sure they have a mammogram every year when they come to see us. And we do a blood workup, and we have a huge questionnaire, and we have you fill out everything about your medical history. So there are many things that you wouldn't think may interfere with your treatment or may make your treatment better that may be in your medical history, but we can see that, and we work with that and try to get your treatment perfect. I mean, your first visit is an hour, your second visit's an hour, which is kind of unheard of except with you.
Right.
And so, and then after we have everything stabilized, we don't order blood work every time you come in, and we don't get paid for your blood work in general, unless somebody has, if somebody has no insurance, then we give them our discount for Quest so that it's affordable. But if you have insurance, we just put it through your insurance, because that's what they're there for. You shouldn't have to pay for that twice. So like there's other places that charge you for it as well. So we don't want to do that. We want to just make sure that you can afford to come back and get your hormones to keep you healthy.
Excellent. All right. I think we already answered that. And then question, does Dr. Maupin recommend patients have a cardiac workup ever?
Yeah, lots.
That's why I know Dr. Maupin.
Yeah, I send people to Dr. Twyman. Yeah. Of course, you know, when people are at high risk, and when we generally fix their thyroid, fix their hormones, and their lipids are still bad, or their inflammation's still high, and I'm worried about that, then I say, you know, I'm worried about this. You can either go get a cardiac calcium scan and see if you have plaque, or you can go directly to Dr. Twyman and he'll do it, and he'll test everything else too. So that's what we do, because we aren't cardiologists. We don't even pretend to be. I mean, we are just out there looking for people who need a cardiologist, and many people don't even know they need one until it's too late. So Mike prevents heart disease. That's what he's trying to do, and I'm trying to prevent everything else.
Right, and sometimes it's a chicken and egg thing. You know, people come to the cardiologist and they have no libido, they got ED, and it's like, well, all your hormones are wrecked. You need to go see Dr. Maupin or somebody who can balance your hormones. So, you know, it just, you know, ask your doctor. If you're not, you know, performing at a peak level, you need to find somebody else who can help you with that. But yeah, she mentioned the calcium score test. You know, that's, you know, the best non-invasive test for anybody over the age of 40. It's like a mammogram for your heart. You know, if you have calcium in your arteries, you got plaque, and you need to figure out what's putting that plaque in the arteries.
And then stop it.
Yeah, and stop it.
But there's a study out that says for when men get ED, it's 3 to 5 years. I haven't read it in a while. 3 to 5 years after that, they're likely to have a heart attack, because it's likely that when your testosterone drops and you then start making even more plaque, that it takes that much time for you to then have a heart attack. So don't have a heart attack.
Yes.
If you have ED, then don't just take the little blue pill. You need to actually be worked up, and you need to have your heart worked up at the same time, because we don't want to have you have heart problems or heart disease. We want you to be well. The whole point here is for you to be well and not need doctors.
Correct. And I think somebody had a question about, I don't know if it says, would you expect or accept. A breast thermography? I guess
We've done that. There are some patients who really are very worried about radiation. I understand especially if they've had radiation for Hodgkin's or something else, they don't want to have more radiation. So we accept thermography. Sometimes we also do an ultrasound of the breast with it because it makes it more accurate. Having said that, I mean, every mammogram can fail, every thermography can fail. So that's why we have you do it every year. Because if they didn't catch it last year, they're going to catch it this year and probably hasn't gone anywhere yet. If it was early and we're watching it every year, it shouldn't have.
Okay, excellent. And I think we may have answered this part, but just to quickly rehash on this, would HRT help the hair loss on the top of a head in a woman?
So I think you're talking about the crown. If it's in the crown, in general, that probably is that either you have a genetic hair loss, like your mom had it like that, your grandma had that, or you have a very high DHT, or both. You can have it be genetic and your DHT is high, and that makes the hair right here fall out and the hair here, it's male pattern baldness. So oftentimes we have other things that we use. I mean, we still give people testosterone, we block the DHT, and then we have topicals that have some estrogen in it and have other peptides in it that actually make the hair grow. And if it hasn't been gone very long, then it's likely to grow back. So we try to work on that.
Yeah. Are you using any type of light therapy for hair yet?
Yeah, we recommend the helmets.
The laser caps?
Laser caps. I have one. I don't need one,
Yeah.
but I have one.
Have one.
I just had to have it.
Yeah. I have a lot of laser toys. I don't know if I needed them. I wanted them. All right. Well, I think we banged through all the questions in less than half an hour, which was outstanding. So I want to thank Dr. Maupin for her expertise and time tonight to share it with the audience of polycardiology. This video is being recorded, of course, and it'll be up on our YouTube channels later. If you have any questions for myself, you can drop them in the DM and I'll get back to you. But Dr. Maupin, where can they follow you at?
You can follow me at biobalancehealth.com, and you can also follow me on YouTube. Every week we do a health cast on various subjects. Most of the time hormones have something to do with it. We've had Dr. Twyman as our guest. So you can look at YouTube, look at Dr. Kathy Maupin or Dr. Maupin, or look at BioBalance, and you'll find us.
Okay, excellent. Well, thank you guys for joining us. Next week I'll be doing a how to biohack a jet lag protocol. I'll be traveling to Europe finally after 18 months being off from international travel. So I'll share some of my tips and tricks on how to hack jet lag. So we'll see you guys next Monday, 6 o'clock Central Time. Have a great week.
Bye-bye. That was great.